Good morning and welcome to Sri CPD webinar. And today we are going to discuss about a very important topic, critical incidents, learning pathway to improve patient safety. So this is a very important topic for us as medical officers because we are every day dealing with a lot of humans and lot of equipments, and we are more prone for very critical incidents, but there should be a learning pathway rather than fault finding. First of all, I would like to introduce some housekeeping matters. So please be kind enough to switch off your microphones and videos throughout the webinar. Otherwise, it will interrupt our webinar. And other thing, the webinar link will be available from 9 a.m. to 9:50 a.m. to join in. No late attendees will be entertained thereafter. And each attendee should have to attend till the end of the webinar to obtain the certificate for CPD points. And the CPD points are strictly adhered to the NCCPD guidelines. So this program is to improve and maintain the standards of the CPD program conducted by Sri. And I'll be thank you very much for Sri CPD for giving me this opportunity to moderate this program today, and also thank you for strictly adherence of the CPD regulations and your kind compliance. So without further delays, and also about the asking questions. So it will be at the end of the webinar, and if you have any questions, please type it in our chat box, and you can change the chat settings to all panelists and the attendees so that your questions can be answered at the end of the session. And if you have very specific concerns about your situation, please email us on officeshri13@gmail.com. And before answering your questions, there will be poll continuing throughout the presentation, and we will be discuss that questions as well before answering your questions in this session. And also regarding the e-certificate, very important thing. So there will be a link in the chat box, and after filling your feedback form and post-assessment questions, you will receive your e-certificate for the participation. Okay, without further delays, I will introduce today's presenter. It is a great pleasure to introduce here today, madam. So our speaker today and resource person today is Dr. Nilmini Wijesurya. Madam Wijesurya is a retired consultant anesthetist, and she had been the head of the department of the Colombo North Teaching Hospital Anesthesia Department. So she's a ERC instructor, and she's the national coordinator of the Resuscitation Council of the College of Anesthesiologists. And most importantly, she is the chair of the Patient Safety and Quality Improvement Campaign, and she is the most suitable person here to discuss these today's topics, critical incidents and patient safety and improving pathway. Over to you, madam.
So, good morning to all of you. On behalf of the College of Anesthesiologists and Intensivists of Sri Lanka, I would like to thank the Society of Health Research and Innovation for giving us this opportunity to update you on critical incidents, a learning pathway to patient safety. And thank you, Pramila, for that kind introduction, and all at Sri for facilitating this program today. So let me share my screen. Right, so in my talk today, I'm going to go through the background of patient safety and critical incidents, some definitions, and critical incident reporting systems, and how we learn from reporting. So first of all, I just want to take you through this incident that happened in a developed country in Canada, Quebec, in 2013, where a train with 72 tanks of crude oil derailed in a highly residential town. And the explosion killed 47 people. There were so many reasons why it happened. The important thing is this cargo still rides the rails. So it's very similar to what happens in medicine as well. In healthcare, we hear a lot of critical incidents, and actions are taken, but they continue to happen. So there's a huge similarity between industrial accidents and healthcare related accidents. So when an adverse event occurs, what happens normally is people try to find fault with individuals. But the most important thing is to find how and why the defense has failed. So there was an inquiry about this railway train accident, and you will be amazed to see the number of factors that contributed to this black magnetic runaway train accident. So very similar to what we see in medicine as well. So they found that the train engineer, normally they stop the train for the night rest, and then he did not apply enough handbrakes. And where he parked the train was on a downward slope. There was a mechanical problem which was not addressed properly. And after some times, there was the engine failure, where the engine slowly started to get activated because the brake system was not adequate, and the train, without any attendants, started to move along the rail track. And then it derailed, which caused an explosion and killed 47 people. And there was a massive loss of property, which was near because of the huge explosion with crude oil. So this is related to healthcare accidents as well, because we can learn a lot of lessons by looking at these factors which have contributed to this, the fourth most tragic event in Canada. So we are going to talk about this Swiss cheese model, which you can see on the right-hand side, where an accident can happen due to the breaching of the successive layers of defenses, which they found in this report. So to relate this to what we see day to day in our day-to-day practice, I have deliberately avoided giving Sri Lankan examples as much as possible because of the issues that people might get hurt or they might take it personally. So this is an incident happened a couple of years ago in the United States, where a young 19-year-old boy came with an illness where he needed liquids and nutrients through a central line in his neck. Okay, so you all can select this question and the answer. So we will talk about the answers at the end. Thank you. Right, anyway, what happened was a nurse came to remove this because he was going to go home. And as soon as this was removed, he became very short of breath. And when the parents were concerned about this, they said that the boy was not very cooperative and he was anxious, and they tried to calm him down. They did not call the medical people immediately. So the patient died immediately in front of his own parents. And this is another case where the surgeons removed the wrong kidney. And obviously the surgeon was devastated after this incident, where he was the main surgeon, and the registrar was allowed to operate on the patient while he was on site supervising. The patient was scheduled for nephrectomy, and the registrar in the clinic put the wrong side in his admittance slip. And this was transferred to the operating list. But the case notes, consent form, everything had the correct information, but the registrar did not look at the consent form or the case notes. And unfortunately, the surgeon put the X-ray back to front, and a medical student noticed this and told that the X-ray is on the wrong side, and she said that they are operating on the wrong side. But the registrar ignored her, and at the end only they realized that they have removed the wrong kidney. So this patient didn't have he had a non-functioning kidney. The left side was the normal kidney, so they removed the normal kidney, and the patient immediately was transferred to an ICU. When they realized the mistake, they were trying to find another donor. So this patient went into renal failure, obviously, was on dialysis and died in the ICU later. And the surgeons had to pay the compensation for that. So the problem of patient harm in healthcare is huge. And due to unsafe care, it's a growing global public health challenge, is one of the leading causes of death and disability worldwide. So unsafe medication practices and errors is one of the leading causes of avoidable harm. So I think we have given some questions. I don't know whether people have given answers. I got some answers. Good. Okay. So it's interesting to be a bit interactive. So we will get this. Okay. So we have got AI embolism for the reason for his death, 82%. Interesting. Yes. Severe bleeding, 9%. Pulmonary embolism, 9%. Okay. So the reason was actually AI embolism because what happened is can you see the results? So 83% have answered like it's AI embolism, which is correct. So for the first question, will you remove the cannula immediately? No, was 95%. That's correct. Because when you remove a central line while the patient is seated, they can end up having pulmonary embolism. Sorry, AI embolism. So patient harm due to, so you can see very illegible prescriptions commonly happening in our setup as well. So unsafe medication, as I mentioned earlier, is one of the leading causes of avoidable harm in healthcare. Incorrect dosages or infusions, unclear instructions, use of abbreviations, and inappropriate or illegible prescriptions. So globally, cost associated with medication errors has been estimated as $42 billion annually. So it's a huge amount. So in Sri Lanka, the same problem, there had been some articles in journals where they found that there are legibility issues and prescription, we can't read anything, completely legible around 9%. These are limited studies, so therefore the numbers are generally only restricted to these studies. So drug interactions, unapproved and error-prone abbreviation use, prevalence of drug-related problems, which clinical pharmacists have identified most of the time, and prescription with an antibiotic in OPD, and generic prescription only about 36% in the private sector. So there had been sentinel events, that's a very harmful events where calcium was prescribed and they look very similar. So patients were given lithium tablets instead, and the lithium tablets cause toxicity in some patients requiring dialysis. And in some other cases, there was an incident where warfarin 1, 3, 5 milligram all came in same color and form, and patient was admitted with heavy bleeding with the INR of 14. So 134 million adverse events occur in low and middle income countries, contributing to a huge amount of deaths every year, around 2.6 million deaths every year. So social cost of patient harm can be valued at $1 trillion to $2 trillion. These are in low and middle income countries. So in NHS, they have found that around 900,000 incidents and near misses are reported every year. Out of them, about 2,000 cause death. On average, an estimated 1 in 10 patients is subject to adverse event while receiving hospital care, even in high-income countries. So it's not related only to low-middle-income countries, but even where there are systems available, this still happens. So now, from the critical incident is our topic, but without talking about the patient safety in general, we cannot immediately go to that. That's why this background information I am giving to you. Patient safety is a framework of organized activities that creates cultures, processes, procedures, behaviors, technologies, and environments in healthcare that consistently and sustainably lower risks, reduce the occurrence of avoidable harm, make errors less likely, and reduce the impact of harm when it does occur. So this is the definition given by the World Health Organization. And our aim should be to develop a positive patient safety culture. It is where healthcare professionals are encouraged and empowered to identify and report potential risks and hazards, learn from mistakes and near misses, and continuously improve patient safety. So because of these problems of healthcare patient safety issues, the WHO partnered with other professional groups, external experts, and healthcare leaders and launched World Alliance of Patient Safety in 2004. The fundamental aim of this was to facilitate the development of patient safety policy and practices in all member countries. Sharing knowledge and resources aimed at improving the safety of healthcare was another aim, and to reduce the duplication, unnecessary duplication. Sometimes when there are things available, why should we start from the beginning? we can just adopt according to our local facilities. So duplication should be reduced and minimize the wastage of valuable resources by coordinating and facilitating the international expertise. So these are the aims of this World Alliance of for Patient Safety. So they introduced the concept of global patient safety challenges in 2005, healthcare associated infections, clean care is safer care. 2009 introduced the WHO checklist, surgical safety checklist to safe surgery saves lives. And 2017, with an aim of reducing global harm by 50% due to medication errors. And now in the era we are is the flagship initiative of a decade of patient safety from 2021 to 2030 to support and guide strategic action on patient safety at a global, regional, and national levels. So how do we find data related to patient safety? So one of the most important things is incident reporting systems. Then the mortality morbidity meetings, complaints, malpractice claims, patient reported outcomes, avoidable deaths. These reports, case note trigger rules, clinical care audits, burden of harm studies, organizational culture surveys, and sentinel event audits. So these are the methods how we can find data related to patient safety. So if you look at the patient safety incidents, you can categorize them into two broad categories. One, which do not really reach the patient. It's about to happen, that is a near miss or a close call, where it would have happened, but for some reason, maybe the luck of the patient or somebody noticed, it didn't happen. Then there are incidents where it reaches the patient. So they can be either harmful incidents or no harm incidents. So incident happened, sometimes a wrong group blood had been transfused, but no harm happened to the patient because either it did not initiate a reaction or the group was not so incompatible. I'm giving a bad example maybe, but other incidents are harmful incidents. They can be two. One is adverse event and the other one is adverse reaction. So the definitions of the patient safety events or issues are internationally classified by the WHO. It's published. So we cannot change the definitions because they are definitions already agreed on internationally. So the adverse event, as I mentioned, so if you look at this, these are two harmful incidents, adverse event and adverse reaction. There's a difference between the two. One is adverse event is a preventable harm to a patient. So that is not due to the patient's complication of the disease, but due to our medical management. So like administering the wrong drug to the patient. Adverse reaction is even if you follow all the correct processes, but it's unexpected and a non-preventable harm. So somebody getting anaphylactic shock to an antibiotic is something that we may not be able to prevent. Then there are other terms like errors. Error is a failure to carry out a planned action as intended, which is error of execution, or a wrong plan to start with. So that is application of an incorrect plan. Then there are other terms like hazard. It's any threat to safety, unsafe practices, conduct, equipment, labels, and names. So there is a bit of a confusion on these definitions. But if you go through this classification according to the international standards, we should always make sure that we use these terms appropriately. So incident or critical incident, which we are talking today mostly about, it's a deviation from usual medical care that causes an injury to the patient or poses a risk of harm. So this includes a broad group like errors, adverse events, hazards, all these are included in a critical incident or an adverse incident. So then, as I mentioned, near miss or incident where there's potential but it did not reach the patient. And there are never events, like the case that I discussed earlier, two cases actually, removing a central line without putting the patient lying down is an event that should never happen. And the other event is taking the wrong kidney out. These are things that should never happen, never events. So then there are sentinel events where an unexpected occurrence involving death or serious physical or physiological damage. This is called sentinel events. They should be investigated immediately. So now we go to talk about in more detail about critical incidents. This is our topic today. So it is an unintended event causing serious harm to the patient, and it happens not only in hospitals. So most of the time the incidents are reported only in the within the hospital, but starting from the primary care, the private sector. So all these should come together, and it is generally not a result of the patient's underlying condition, and they are not also risk of or inherent in providing of the health services. So it is an unintended event causing serious harm to the patient, which may end up in death or other things like disability, some injury or harm, or it can be unplanned admission to hospital or unusual extension of a hospital stay. The wrong surgery, wrong site or site, wrong medicine, wrong dose that causes serious harm to the patient, and breakdowns in communication, especially during transition and handing over, taking over, delaying in treatment or not receiving treatment, which causes preventable adverse outcome to the individual. For example, if the patient comes with septic shock and you do not adhere to the septic bundles, this patient might end up either dead or serious multi-organ failure, leading to prolonged ICU care. So this is also a critical incident, which people might not think it is. So how do we prevent critical incident? So for this, the WHO has given guidelines, patient safety incident reporting and learning systems, because we learn from the incidents, and unless we report and analyze them, we will never be able to prevent future incidents from happening. So it is a key component of patient safety, which is underutilized in healthcare. It is influenced by involvement of experts on safety outside healthcare and public concern. So the main aim is to improve patient safety, and critical incidents and near misses, learn from the experience of others. So I would also appreciate if you all from time to time answer these questions so that we can come up with some data, because whether there's a system or not in the hospital is something that these are all confidential information, so don't worry about it. So learn from the experience of others. This is another important thing from critical incident reporting, and it should include to find the reason for the incident and have systemic changes which will prevent it from recurring. So now what is expected from this patient safety reporting and learning systems? So that what is expected is actually we must learn from the things that go wrong. It's like the derailment of the train. So there was a recommendation that they should bypass the train tracks from the center of the city, but they continue to go through the city still. So similarly, we expect that we must learn from the things that go wrong and take enough precautions. But what actually happens is that we will think that we will learn from what goes wrong and this keeps on happening. So very basic principles of incident reporting includes that we should make the risks visible to everybody, and we should prevent harm, and we should engage the local staff who got involved in that particular incident. So learning from critical incidents have this kind of steps that we should follow. So first thing is the incident should be reported. The report should be assessed. Then you have to investigate to find the causes, and we must make system insights to see why it happened. Then we have to develop an action plan so that we can prevent future harm. So this type of learning from critical incidents increases the understanding of why an incident happened, and then it guides which behavioral, organizational changes or actions are needed to prevent future harm. So there are 4 basic activities we must remember. The first one to start with, obviously, should be data input. Unless somebody gives the data, we will not know. And it should be independent and non-punitive. So the punishment should not be the result of putting the data. So people will not give any data if you think that you are going to be punished. Then the data, what actually happened. Analysis is very important, because just reporting the data is not enough. Nobody will know what has happened. So you need to analyze, which turns a report into a lesson. Then giving feedback, The goal must be to learn from mistakes and to ensure that systems are improved for better patient safety in the future. And all parties involved must be prepared to share ideas, abandon defensiveness, and put blame and recriminations aside. So what happens is, generally, if it is only the data input without talking to the people who got involved, you will really not get the correct idea. Because if the person who was really not involved is not given a chance to explain what happened, we might only find fault with the person who was very directly involved with the incident. So it has to be that all parties should be involved when you prepare the report or you actually put the data. And these people should be given a feedback about what could have been done to avoid this mistake in the future. So the WHO has provided a minimal information model for patient safety, incident reporting, and learning systems, which is called MIMPS. And there are basic and advanced, because if you look at your day-to-day clinical practice with busy clinical setup, people will find no time to do more and more writing. So it has to be very clear and short and sweet so that people have time, and it's not a very daunting task to fill these forms. Because if somebody is not giving critical incident data reporting, there's nothing for us to talk after that. So first important step is the data input, and we must have a simple system to facilitate that. So if you have a long list, people will stop writing and reporting. So it's very important to have these very simple looking data forms so that everybody is encouraged to report incidents. So the Ministry of Health, with the Directorate of Healthcare Quality and Safety, has produced guidelines which have been published, and circulars had been sent to institutions. But I'm not sure whether they have been reaching the patient caregivers, actually, the people who are directly involved with patient care. Because I think the problem with the ministry and the institutions is that there is a barrier between us that prevents from all the important. They do a lot of hard work, and we do not sometimes see the result because there's a communication barrier between the ministry and the institutions. So there should be people who should be able to reduce this gap and make incident reporting and analysis procedure to happen more effectively. So if you look at this, you can find this in the Directorate of Healthcare Quality and Safety website and Ministry of Health website as well. I'm sure all your hospitals have received this. And there's a process of handling adverse events and incidents. So they give a good guideline about what to do when you find when you come across an incident or critical incident. So first important thing is you have to appropriately manage the patient and make sure that the patient gets the best possible care. If the patient needs tertiary care or more specialized care, you might have to transfer the patient once the patient is stabilized. Then only you try to fill these adverse report forms that are available in the website, and they have been circulated to the hospitals. Quality management units are responsible for doing this. So there is a form which you need to fill if there's a critical incident and hand over to the health quality management unit. And I know that some hospitals don't have quality management units, and because of the staff shortages, the doctors who have been appointed are also requested to do other jobs as well. So this does not happen, I think, as they expected. Then individual professional groups have produced their own methods, like College of Anesthesiologists and Intensivists of Sri Lanka. We have anesthetic incident reporting forms, which people can access via the website, and they are supposed to upload that. And we had a very good system with Dr. Dayantha Jayasuriya, our senior consultant, who had been doing this for a long time, analyzing them and feeding back to us. And we in the process of reviving it and making it more available to all throughout the country. And the Sri Lanka College of Obstetricians has produced a maternal death notification form as well. And this is supposed to be sent to the college by email. And I really honestly don't know how they manage that. But I'm sure they must be doing their own way of, they must be having their own way of giving the feedback to the, because ultimately after reporting, unless you get a feedback, there's no point of reporting. And people get frustrated, okay, we have reported, but we don't know what really happened. So we need to make sure that we analyze them and give a feedback with some guidance to what to do for preventing it happening from in future. So for a successful incident reporting, the clinician should have easy access for reporting. And as I mentioned, the form should be simple, easy to fill. And most of the countries have developed electronic forms, electronic records. At our college also, you can do it electronically. So that because most of the, especially the young population, young doctors and nurses, they are more familiar with the electronic systems. And you can access it with your phone and quickly fill it. And very important thing is, why don't people report incidents? Because they are scared of the punishment. So they think that they might be punished. Because still we are not in that situation that we understand that the system should be blamed more than individuals, unless there's a gross negligence by an individual. So it's a system that makes these incidents to happen. So the no punishment guarantee, it's in actually the the Ministry of Health incident form, it is mentioned that you are not going to be punished for this. So this type of guarantee should be there so that people are encouraged. And also, you should not be judgmental at an individual level. So finding fault with a person, if he was grossly negligent, there should be a disciplinary action. That's a different story. But when you discuss this in a forum, like a mortality, morbidity meeting or something, we should not point the fingers to an individual. Oh, this happened because you didn't do this. We need to find why did that person not do what he should have done or did something that was not supposed to be done. So we need to look at the system. So this is the current trend, to find the system problems rather than individual problems. And then, so for that, you need a multidisciplinary investigation. So you should have external, especially expert inputs and interviews of those who were involved in the problem, which will give you in-depth analysis of what really happened, and try to reconstruct the events that occurred to see why it went wrong. So if you look at now incidents, like I mentioned, the railway accident and the accidents that had happened to patients, they have a lot of similarities. So the incident reporting in other industries are also very similar to what we do, and we have learned a lot from the other industries. And if you look at the mismatch between these two groups, other industries and the healthcare, in other industries, if you look at the incidence of plane crash, it is actually a very rare thing to happen, although it gets a large amount of publicity in the media. But it's very, very safe to fly when you compare to what can happen when you can come to a hospital. And they focus on reporting incidents that provide serious, specific, and surprising insights into system safety. By doing that, because they select the serious ones, and by doing that, they stop overloading the reporting system. So what happens in the healthcare is we want to get everything reported. So sometimes all unnecessary things also come as a report, and we have no time to analyze them. So we don't get enough information. So we just want to have a lot of data, but we will have no time to analyze them and provide reports and give some feedback. And so in other industries, again, they use reporting to identify and prioritize significant new or emerging risks. And they are generally managed by an independent group. Unlike in healthcare, we always have our own people getting involved. Sometimes we may be biased because of that. And they use automated technical information, which is really still not widely available in healthcare. So if you look at the incident reporting in aviation, they have about 50% of the data are individually reported, and also they are automated, captured, and analyzed. In healthcare, most of them are self-reported, and that is also less than 50%. And automation is still a long way to go in healthcare. So when you analyze we should take the human factors model, which has a standardized framework, and it emphasizes the significant shift from traditional judicial approach. That is, you are trying to find the fault with one person, but to understand how latent errors may play a role in the chain of events which can set up an active error to occur. So without blaming each person, we need to find why these barriers were breached. If you remember this Swiss cheese model that I showed you at the beginning. So this framework for the UK, they have developed this type of a contributory factors and main factors for each to analyze critical incidents: institutional, organizational, work environment, team factors, individuals, task factors, patient factors. And in the Ministry of Health, there's a category on the right-hand side. You can see this is the category of incidents that they have categorized for the easiness of analyzing them. So, assessment of patient safety and incident reports have to follow this. You review individually, investigate fully, and study in aggregate. Then only you will come to a conclusion of what really happened. So this model is, if you have seen Swiss cheese in the supermarkets, where there are a lot of holes, which generally do not come as one single line, but the breach of the defenses at every stage can ultimately lead to an accident like this. So those are the factors that I mentioned earlier. So the human failure types have been given a huge importance in nowadays incident reporting, because the human failure, whatever you do, is something that we cannot avoid. So they can be inadvertent or deliberate. So deliberate is the non-compliance or violation of a routine or situational or exceptional things people do sometimes out of whatever the reason, negligence, maybe do not care. And then inadvertent failures are errors, which can be an action error or a thinking error. And they can be slips, lapses, or mistakes due to a rule not being followed or knowledge is not adequate. So if you look at the systems in which can fail us, even the humans, you can see it's very complex infusion pump. Sometimes with small letters we can make mistakes. And bad, signing. And if you look at these vials, you can see that all of them look same. So somebody can put everything into one bottle or one locker. And here one is heparin sodium. So you can give this to a patient and cause harm to that patient. So these are systems that we should improve. And look at this. So is it not going to cause errors to any human being? One nurse looking after this tiny little baby with so many machines attached to, it's a system that actually can fail us. And if you look at the aviation, and on the right-hand side, the anesthetic machine and equipment that we use, again, prone to error because there are so many machines and stuff around. So learning, formulating action, and managing the change. The ultimate aim is to reduce the risk of harm, not just understand what went wrong. Advisory notes, guidance papers, standard operating procedures, warnings, alerts, regulatory rules, product changes, and articles in professional journals are the feedback, the way that you give the feedback to people, not only the people who got involved in the problem, but people who are outside, so that we learn from other people's mistake. And then technical solution. There was at one time people getting cardiac arrest, people who were on KCL infusions, getting cardiac arrest very often. So they found that all the drugs are kept in the same place, and there was no specific instruction that KCL can cause cardiac problems. So then there was high alert about potassium chloride injections. They were supposed to be locked, and there was this immediately reduced the number of adverse events. And similarly, bloodstream infections are very common in especially the intensive care units. So introducing catheter care bundles has tremendously reduced the incidence of catheter care, catheter-related infections. So the feedbacks that we give through these methods can be not very effective if people are not engaged. The people who are in the loop, these are the clinicians, so they have to be regular. So if you send one notice at a time, after 1 year, they will forget about it. So there should be regular feedbacks about things that can go wrong. So these are the examples of alerts that you can either send through the WhatsApp groups, social media, or I mean media. I don't mean that social media that can be accessed by the public, but among the professional groups or emails or leaflets, something like that can be used. So, and also make things safe by making them, people can see things to read this for relaxant. So you don't go and give relaxant instead of distilled water or something, and labels and simple low-cost solutions like here in Sri Lanka, some pharmacies they use where all the drugs are having similar names like Phenergan, prednisolone. So starting with the same letters. So you can make cost-effective solutions to low-cost solutions to avoid harm. Having standardized mortality morbidity meeting presentations using situation background assessment or root cause analysis of the contribution which contributed to the complication, and review of literature with recommendations is an important thing that we are adopting in anesthesia. It's a future plan of the college to have this system in all M&A meetings that we do in all hospitals as much as possible. This is one of our projects. So engaging patients and families, this is an important thing. A single death is a tragedy for that family only. But for us, it becomes 1 million of deaths, and it's only a statistic for us. So patients who suffer harm and their families should be fully informed of what has happened and how it happened and what will be done to prevent another similar occurrence. It's a very challenging thing, very difficult, because we are scared of being legally responsible when we try to talk to the patients' families. So there should be a local and ministerial level guidelines of how to do and what to do. And involvement of experienced clinicians is very important in handling these difficult cases. And it has to be an integral feature of the best reporting systems available in the world. So I'm going to now talk about this story to conclude with, to give you an idea about critical incidents and what we should do and what we can learn from them. So this is the husband story, from tragedy to learning and action. All the anesthetists generally know about this incident. Maybe you all have heard about it. Martin Bromley is an airline captain now living in the UK. He founded and he's the trustee of the charity called Clinical Human Factors Group, and it works with healthcare professionals, managers, service users in partnership with experts in human factors from healthcare and other industries to campaign for change in healthcare. So he unfortunately lost his wife due to a medical error, and please listen to him and learn some lessons from this story.
My name is Martin Bromley. I'm dad to 2 young children, Victoria and Adam. And this is the story of the death of my wife, Elaine, who died in March 2005 as a result of an attempted routine operation that went wrong. I'm an airline pilot with a background in human factors. I want to make a difference. I want to be able to say to Victoria and Adam in a few years' time that although their mum died, the lessons from that have been learned, and that there is a change in practice in healthcare in the UK.
His aim is to improve patient safety. So this just a routine operation is available on the YouTube. If you want to see, I have been just
My name is
taking
Martin Bromley.
small parts of it. Elaine was 37 years when she came for a routine sinus surgery. And preoperatively, the anesthetist found only congenitally fused vertebra without any involvement of the airway. There was no alert about any airway difficulties. And she was planned to have a operation.
Elaine was being cared for
flexible
by an
laryngeal mask
experienced anaesthetist and his experienced assistant. The plan was that they would start with a laryngeal mask, and they had done a very thorough pre-op assessment. There were no undue causes for concern at this stage. And at 8:35 in the morning, Elaine was anaesthetised.
Off we go.
So they struggled to
Second.
put the laryngeal mask.
Yeah, hold down a bit. Let me push the head back a bit more.
They then tried some extra drugs to try and reduce some suspected tension in the muscles in the jaw. So it was obvious almost straight away that things were going wrong. We know that 2 minutes in, Elaine's oxygenation was 75%
So
of
after
full length,
induction, 2
and
minutes,
she was by this
saturation
time already
dropped to
visibly blue.
73.
Within 4 minutes, we know that her oxygenation had fallen to 40% or lower.
In 4 minutes, saturation was only 40%. And they still struggled to get an airway in without trying to wake her up.
Her oxygenation is 40% or lower, and it has been for 6 minutes. The anaesthetist has 16 years experience, and he is regarded as diligent by his colleagues. The ENT surgeon has over 30 years experience. The other anaesthetist has additional skills pertaining to difficult airways. The 3 of the 4 nurses were all experienced in their job. And it's perhaps worth just wondering at this stage what was going through their mind. The intubation attempts had failed. The oxygenation was very low. What we know actually happened is at this point in 10 minutes for a further 15 minutes, the 3 consultants would appear to have continued with their attempts to intubate to the exclusion of any other option. And that at the end of that 15 minutes, we're now 25 minutes into the whole procedure, they eventually get Elaine's oxygenation to 90%, but she's actually been at 40% or lower for a total now of over 20 minutes.
Okay. Can we get above 90? No.
They fiddle around a bit more, and in fact, her oxygenation falls again below 90% for a further 10 minutes. And finally, by the time we're 35 minutes in, they seem to make the decision that the best thing is just to let her wake up naturally.
Let's wheel it back. Quick as we.
And they transfer her to the recovery room. She lays there for an hour and a half, and of course, she never wakes up. Based on the evidence from the inquest and from Professor Harmer's report, the lead anaesthetist, if I can call him that, in his own words, lost control. There was a question mark in the inquest about who people felt was in charge at different points. There was certainly a loss of awareness, an awareness of time, but also an awareness of the seriousness of the situation. If you like, the awareness of what was happening wasn't shared by each of the consultants.
So there was a problem of they did not realize that the time was running and she was not getting the saturation up. So they were still struggling, and there were concerns from the other.
The nurses were generally aware of what was happening and what needed to happen.
Felt that something is
When
not
I
right.
said to you that 6 to 8 minutes in, the 3 nurses arrived, one of them asked her colleague to go and fetch the tracheostomy set. There was already a quick trachea kit in theatre. She went out, she collected the tracheostomy set, she came back in, she announced to the consultants that the tracheostomy set was available, and there was no response.
So she bringing the tracheostomy and somebody else asking
One
for
of
an ICU
the
bed
other nurses
was not taken very seriously by the consultants. They were just trying to get the airway And later, the patient was taken to the recovery without intubation and transferred to the ICU. And after that, 13 days, she was severely hypoxic, brain damaged, and the husband agreed to disconnect her from the ventilator, and she died 13 days after the incident. 37 years, mother of 2 children. So now Martin has taken the lead to prevent things from happening like this, and he's a huge advocate of patient safety healthcare, especially human factors, because that is his interest in airline industry as well. He's still working as a pilot, giving talks and organizing a lot of charity work and education for healthcare professionals in this.
From the inquest.
So there was an inquest about it, and it was amazing to see how people did not realize
when we get out to the aircraft, there's a lot of technical jobs that need to be performed. There's the usual security checks of an empty aircraft. There's the safety checks, both of the outside. We have to do a walk around, making sure the systems are functioning and that everything we require for flight is switched on or operating in the way it should. Having done all the preparation, got everything ready for flight, we then get together in a briefing. And that's really to make sure that we both know what we expect to happen, but more importantly, that we think through all the possibilities. Up to 100 knots, you'll consider stopping for any ECAM warning or caution. Above 100, you'll only consider stopping ECAM warning, engine failure, something you think is going to stop us flying. 3 things to remind me of. With a positive climb, we'll get the gear up if appropriate. Remind me that TOGA's available. Remind me that autopilot's available.
So they go through all the checks, double check and have a plan if things go wrong, which we might not do all the time when we deal with our patients. So this is a lesson that we can learn. So from the report of this inquest, the key teamwork lessons were learned. The communication breakdown. There was nobody vocalized that it was a can't intubation, can't ventilation situation, which is an emergency in anesthesia and intensive care, where you need to get oxygenation as a priority. And they did not have a clear plan when crisis happened. We call it the Difficult Airway Society guidelines are very clear on what to do, and we have plans to activate if there's an airway crisis. And listening to all team members was completely neglected. And even the nurses, when they felt, they were less assertive. They did not manage to raise the alarm. But above all, sometimes we do not like to listen to our juniors or a nurse or a medical student telling us off, okay, you are not doing it right. So therefore, we must have a culture of listening and the control. So there was no leader in this whole thing, and the lead anesthetist, the person who anesthetized, has admitted that he lost control, and they lost control over time. They did not realize that they have taken more than 20 minutes, her having very low oxygenation. So the leadership is an extremely important thing in teamwork. And without a good leader, there are a lot of people trying to do independently to achieve the goal, which we might not achieve. So Martin says that we are all wrong, no matter how good we are. We need people around us to tell us. Be open to suggestions and listen to your team. Step up and lead. So these are the learning points that we should learn from this unfortunate tragedy. And this is one that is important for us to understand. And engaging family and friends of the person who gets involved with a critical incident or even death sometimes, if we are compassionate and we discuss with them of what happened and be honest with them, they might even come up like Martin to help to improve healthcare safety systems, which he's doing a great job by doing that. So what are the challenges for us to implement critical incident reporting and improving patient safety in our country? We have a poor safety culture, unfortunately, and we are very scared of punishment. So people just don't want to come out unless it is obvious. So near misses are completely not reported most of the time, although there are systems that encourage people to do that. But this fear of punishment is the main issue that we need to guarantee to get a good result of incident reporting. So the guidelines established by the Directorate of Healthcare Quality of the Ministry with professional colleges, it's being now being done. We are doing a training module for the doctors and nurses as well, and they have established quality management units in hospitals. So something is being happening. It will take time. Even in the developed countries, it's not easy to establish these ideal systems. But we need to start from somewhere. And limited incident reporting, learning, and prevention is another challenge that we have. So we need to follow the guidelines issued and have mortality morbidity meetings. These are, I think, responsibility of the consultants, getting their juniors involved and learn lessons from events that happen to prevent them in the future. And we also have a lot of medication related errors. And sometimes we have graduate pharmacies, but there's lack of clinical pharmacy services like in developed countries in Sri Lanka. Electronic prescribing is not available, so we cannot read what we write. Even we can't find it sometimes. And there are staff shortages, especially in this crisis. People are migrating, looking for better places. Yes, therefore, the workload, which was already huge, is, I think, getting even worse now. And there's very poor regulation of private sector pharmacies. They sometimes run without a qualified pharmacist as well, so giving rise to medication errors. So if there are any questions, you can either put it on the chat box and you can unmute and ask questions if you like to ask. There is a question here. Is it a must surgeon to be present in theatre when induction for surgery in case of anesthetists fail to secure the airway? This must be a question from a surgeon. It's like this. Sometimes surgeons do not stay in the theatre when we anesthetize. We also don't like to be watched. But surgeon being around within the theatre complex, I know there are issues. Sometimes the surgeon calls to say, I am downstairs, I am coming up. But good practice is to have the surgeon in the theatre complex. And I think all anesthetists should be trained to use front of neck access or surgical cricothyroidotomy. So that should be a part of essential training for all anesthetists. So sometimes if the anesthetist is scared of doing this, we can ask the surgeon to do it for us. But if they have not done it, it is a very simple procedure, but definitely surgeon will be more available to do a surgical incision than the anesthetist. So yes, it's good practice to have the surgeon within the theatre complex when you induce the patient in case there is a problem, not even airway problem. If there is another critical incident, we need people. So somebody is asking, can we predict can't ventilate, can't intubate situation? No, can't. We can only predict difficult airway. Right. So if there are no more questions, I think we'll go through the poll at the end, what we couldn't do. So to summarize, critical incident reporting is a key component of patient safety, and it can occur in the hands of very highly skilled and best clinicians. So we should never be egoistic about, oh, it will never happen to me. It can happen to any of us, even in the presence of adequate monitoring and all the facilities. And protocols and policies should be put in place to avoid errors. And it's very important to have simulation-based training. And the webinar today we had was one of the awareness raising programs. And this type of protocols and policies should be available. And the critical incident reporting should be introduced and encouraged in all departments in a blame-free culture to improve patient safety and reduce the morbidity and mortality. And remember the last slide. This is what we should do when you do critical incident reporting. The 4 important points in the critical incident reporting and learning system. So data input, and the data should actually say what actually happened. And we need to analyze the data so that the report can be turned into a lesson. And what we learn is by giving feedback, not only to the people who were involved in the incident, but to all of us, because we can be the next people who might face a similar situation. So this is to ensure that we have the systems that we can improve for better patient safety in the future. So these are my references. I have taken a lot of references from the World Health Organization, which is doing a wonderful job with the organizations throughout the world to improve global patient safety. And thank you very much for listening. And patient safety should be our priority. So we'll quickly, I'm sorry for a little, we are running 5 minutes late, I think. No, more than that. Because of the technical problems, it always happens. So we will look at the poll questions. I think the first two cases, the patient case we discussed. So I think some hospitals have, now this question is, if you have an incident reporting system, does your institution analyze and provide feedback? So 46% have said they do, 26% say they don't know, and there is no in 31%. So that means more than 55% of the time, I think the analysis and feedback is not given to the staff. Do we have any more results, Pramila?
I also can't see more. Madam.
Can't see anymore, right? So it's just we wanted to see, okay, there's another one. Do you know about the adverse events incident report form issued by the MOH? I think a lot of people know about it. I think we should go for electronic recording as soon as possible, because it's easier when it is electronic. Even when you look at the form, I found that it is very, very, you have less space to write. So having an electronic record will improve the collection and sharing information. Okay, are there any more questions? Poll questions coming? Oh, somebody is asking, what are the critical incidents have you seen in Sri Lanka? My God, if I want to tell you all that, I need another half an hour. I mean, with my experience about 31 years in the government sector, I have seen enough. I didn't want to bring them into this discussion because sometimes they can be taken personally. That's the reason. Critical incidents are things that happen. When I was at Ragama, we used to have mortality morbidity meetings in every month about anesthetists. So anesthesia plus intensive care as well. We started doing intensive care critical incident M&M meetings when Dr. Udaya Rodrigo, I must remember that she is the one who initiated this mortality morbidity meetings in intensive care. That is something that people do very seldom, intensive care critical incidents. So there had been, every month we actually have sometimes 3-4 incidents which we discuss and give feedback to our doctors. And airway incidents are very common in anesthesia. And most of the time, I am asking about specific ones which you remember. Okay. So I remember the last one before I retired, a patient who had tension pneumothorax. It did not actually cause that much of tension, but about to cause tension pneumothorax after a patient undergoing a poem, that is the that you do per oral endoscopic this procedure for reflux. And this patient, after the incident, became very breathless, and there was a lot of subcutaneous emphysema. And he ended up in the ICU ventilated to find that he had damaged a small tear in the esophagus, which caused subcutaneous emphysema. But he went home without any problem. So critical incidents are something that is in our life every day, especially in anesthesia. Is a very dangerous area where critical incident can cause, especially airway incident like Elaine's case, can cause severe damage to the patient, death or severe hypoxic brain injury. I think you know some people who are still after critically damaged, still in ICUs, being sometimes it's difficult to decide whether to remove the ventilatory support or not. So I think who is responsible for data collection? It is the answer is quality management unit. The responsible collection is mainly what I meant was the complete collection from a hospital, because actually when a critical incident happens, generally there's no way that the consultant will not know. Okay, I remember another incident where a patient, one of my doctors have put a central breast cath, and the patient was supposed to go to Colombo. That time we didn't have dialysis facilities at Ragama. And when the patient went there, even he went, and then they were trying to connect him to the dialysis machine, and the dialysis machine wouldn't work. There was some obstruction. Then I got a call from my doctor apologizing for not telling me early that he could not find the guide wire. After he looked everywhere, he couldn't see it. He thought that the nurse would have discarded it into the sharps bin. So I immediately told them to take an X-ray to find that the guide wire was in the vessel. So he has lost it in the vessel. And then because of that, the machine was not working because there was an obstruction. So we had to call the vascular surgeons, and they operated and took it out. So patient didn't end up with any major problems, but it was an actual harm to the patient. So he would have got a major problem if it was not informed. So it's the responsibility of the consultant to make sure that these critical incidents are collected and reported and analyzed and discussed and given a feedback. But unless you are told, you will not know. So that is why it's important when it happens. So there was no blame. And at that time, I said that this could have happened to me as well. So it's how we make sure that our junior doctors present these cases or they discuss. So it has to be from the consultants to find a no blame culture. But if it was a very severe breach of care to the patient and there's negligence, you can discuss at a M&M meeting without pointing fingers, but separate disciplinary action will have to follow if it has been a gross negligence from that person who got involved. Thank you. I think we have ran out of almost 25 minutes beyond our scheduled time. So shall we then stop from here? Thank you very much for joining today. I hope that we all learned some lessons. And on a Sunday morning, I know that most of you all have the free time on a Sunday morning. Thank you very much for joining with us today. And thank you, Shri, for inviting the College of Anesthesiologists and Intensivists of Sri Lanka to deliberate our people on this critical incident reporting and learning systems. Thank you very much.
Our sincere thanks to Dr. Nilmini Vijaysurya for her excellent lecture and the precious time. So I think you have learned a lot from her presentation. And regarding asking questions, you have already asked, and the madam has answered already. So if you have specific concern about your situation, please email your question to office313@gmail.com. And again, about the certificate, you can find the link in the chat box and give your feedback and answer the post-assessment questions as well. And then you will receive your e-certificate for the participation. Thank you very much again, madam. And thank you very much for all for your patient participation for the program. Thank you.
Thank you. Have a good weekend. Bye.